Hello and welcome to another intensive care hotline and intensive care at home emergency question and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm your host of the show today, and I also want to welcome our viewers on replay because I know we're getting a lot of views on replay as well. Now, we go for about an hour. You are welcome to ask your questions, type them into the chat pad, or you can join me directly here on StreamYard. And you can talk to me directly. You don't have to go on camera. You can go on camera, but you don't have to. Whichever way you want to communicate with me here is fine. But the quickest way to answer your question is to come here live on the show and talk to me directly on StreamYard on camera. Now, what makes me qualified to host an emergency question and answers for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background, and I have been working in critical care and intensive care for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I've been consulting and advocating for families in intensive care all around the world with intensivecarehotline.com since 2013 at intensivecarehotline.com, and I can very, very confidently say that we have saved many lives for our clients in intensive care, and you can verify that on our intensivecarehotline.com testimonial section, or you can verify it on our intensivecarehotline.com podcast section, where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending critical care nurses into the home for predominantly long-term ventilation and tracheostomy for adults and children, BiPAP, CPAP ventilation without tracheostomy for adults and children, tracheostomy care without ventilation for adults and children, home TPN, home IV potassium infusion, palliative care, ventilation and tracheostomy weaning at home, managing central lines, PICC lines, Hickman's line, and port management at home. And we are employing hundreds of years of critical care nursing experience in the community. That is unmatched and unheard of. We're bringing the highest skills in the community that there are available for intensive care. We are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC and WorkSafe in Victoria, DVA and NDIS all around the country, iCare in New South Wales, NIISQ in Queensland. We have also received funding through public hospitals, private health funds, as well as departments of health. We're also providing level 2 and level 3 NDIS support coordination. Now, and if you want to support the work that we're doing here, click the like button, subscribe to my YouTube channel, and leave your comments, ask questions so that I can make better content for you, because my content is driven by the questions that you are asking. It's rather simple. So without further ado, let's go to the first question that came in during the week. In the meantime, you are welcome to ask any questions here that you would like. Type them into the chat pad, or talk to me live here on the StreamYard link. Now, the first question that came in this week is from Kim, who says, "Hi Patrick, my 70-year-old dad has been in ICU with a ventilator and a tracheostomy for 4 months. He's had COVID pneumonia. He's still stuck in ICU and he can't come off the ventilator. I want to take him home, but it seems to be impossible to take him home." From Kim. Well, Kim, I'm so glad that you've asked, and I'm so glad you're putting forward this question, because in our world, nothing is impossible. We don't use the word impossible. It is absolutely possible to take your dad home. You just haven't come across the right people and the right information yet. It sounds to me like, you've only come across our website now, which is probably why you're reaching out now. But, it's never too late. It's better late than never, right? So what needs to be done in a situation like that? First of all, what needs to be done is we need to have a meeting with yourself and your family and your dad, and also with the intensive care team, establish the clinical realities, right? What your dad is facing, and then we come up with a plan in how to take your dad home safely, and more importantly, keep him at home predictably, right? You don't want to go home and then you're bouncing in and out of ICU. You don't want that. You want to avoid that, right? So that is the first step. The next step is someone needs to pay for it, and that someone could be your dad's health insurance. That someone could be the Department of Health. You know, doesn't really matter who it is, but there is a business case. Keep in mind that someone is paying $5,000 to $6,000 per bed day for the intensive care bed, right? So intensive care at home is approximately half of that, right? So it is a no-brainer that someone, whoever's paying for the intensive care bed now, would want to pay 50% of that, especially since the dynamics are the ICU wants your dad out, you want your dad at home, your dad wants to be at home, and the funding body will have an interest in cutting the cost by 50%. Win-win situation, right? And it's absolutely not impossible. I mean, we have delivered hundreds of thousands of hours of intensive care at home nursing, hundreds of thousands of hours. We're probably coming close to the 1 million hours mark, right? So, you know, the concept has been proven beyond the shadow of a doubt. So for you to say it seems impossible, you know, I completely dismiss and I say it is absolutely possible. We just need to move the right pieces around, right? So once the funding has been established, then we will look at getting a team together, setting equipment up. You know, we've done it so many times. You know, get a team together, organize equipment. You know, and we hand select our staff that are critical care nurses that actually can work in a home care environment, that are skilled to work in a home care environment, right? So that is in a nutshell what you need to do. It's simple. It's simple. I'm not saying it's easy, but it's simple. It's straightforward. You know, one of the important aspects here is don't overcomplicate. Very important that you don't overcomplicate, you know, and certainly we don't overcomplicate. We just get things done. We just get things done. Okay, then let's move on to the next question. Unless if someone on the call has any questions, type them into the chat pad or connect with me live on the StreamYard link here and talk to me directly, and you can get your questions answered here. And just like we promised, we improve your life instantly. I improve your life instantly by answering your questions. Okay, so let's go to the next question from Camille, who says, "Hi Patrick. My mom has been in and out of hospital for the last 6 months. She has stage 4 lung cancer with a collapsed left lung, tracheostomy, and has a PEG tube. She had started to walk again, eat, and speak with a speaking valve, but she was recommended that she go back to the hospital for blood coming out of her tracheostomy from the SNF she was at. SNF stands for Skilled Nursing Facility. And I just want to pause the email here. Whenever you have a loved one with a tracheostomy and ventilator, PEG tube, going to a SNF, it's almost a death sentence. Right? It's almost a death sentence. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That's exactly what this family is dealing with. You know, if this family had reached out 6 months ago, I would have said, no way can you let your loved one go to a skilled nursing facility. No way can you let your loved one go to an LTAC. And here are the strategies to prevent your loved one going to LTAC and SNF in the first place. It's all about getting predictable outcomes, right? And if you can't get them, that's okay. That's okay. If you're battling the system, reach out to us. We're getting results here. We're known to get results. You can once again Look that up on our testimonial section at intensivecarehotline.com, or you can look it up on our intensivecarehotline.com podcast section. Let's continue the email. After my mom got readmitted into the hospital, after 1 day, she went into cardiac arrest due to not being able to ventilate from the blood clots coming out of the tracheostomy. The ICU doctor told us she was not going to make it through that night. Now, for anyone with a ventilator and a tracheostomy, they need to stay in intensive care until they're either weaned off the ventilator and the tracheostomy, or they can go home with intensive care at home. There is no way that a skilled nursing facility or an LTAC is safe to look after ventilated and tracheostomy adults and children, which is why Kim's mom bounced back into ICU in the first place. The number of times we are faced with our clients in the US that go to LTAC and then bounce back to ICU within 24, 48 hours is ludicrous, right? We see it all the time. But it is also up to you to manage that. It is also up to you to take full responsibility of what's happening. It is also up to you to not let it happen in the first place. So, once again, just coming back to Kim's email. After the 1 day at the hospital, she went into cardiac arrest due to not being able to ventilate from the blood clots coming out of the tracheostomy. Well, there's a very high chance the skilled nursing facility missed all the warning signs of having blood coming out of the tracheostomy. After all, you don't get ICU nurses in a skilled nursing facility, right? And therefore, and that's the very reason why ventilated and tracheostomy adults and children are not safe in either LTAC or in a skilled nursing facility. The email continues from Kim. After 1 week, they tried to put a stent in, but were unable to due to blood accumulating in the left lung. They also found out that there's a tumor there as well during the bronchoscopy. They recommended that she be put on comfort care, but we refused as her wishes are to continue treatments. After 3 weeks, she was transferred into the step-down ICU unit and is now fully awake and alert. Bear in mind, this is after the ICU doctor told them she won't survive the night. So what does that tell you? It tells you that you can't trust the clinical judgment of this particular ICU team, right? It's now months later and weeks later, and she's still alive, and ICUs are telling the families, oh, your loved one won't survive the night. Well, after having worked in critical care nursing for 25 years, I think I can give you a good indication when someone is going to survive or when someone isn't going to survive the night. Of course, there's always exceptions to the rules, but there are clear signs when someone is approaching end of life, and there are clear signs when someone isn't, right? So just because the ICU team is telling you something, you have to ask the right questions, and you have to question everything. Imagine Kim would have given in and would have said, yep, let's just take everything away and let my mum die. She wouldn't be here now. Why is that? Why are ICU teams trying to rush end of life? Why are ICU teams trying to kill someone? Why are ICU teams trying to create this negative and doom and gloom narrative? What's the agenda? Well, the agenda is to empty ICU beds as quickly as possible, dead or alive, right? Whether it's sending them out to hospice and let them die, or in the US in particular, sending them to LTACs or skilled nursing facilities and let them die there. There's no holistic care. Okay, let's continue with Kim's email. After 3 weeks in ICU, she was transferred into the step-down ICU unit and is fully awake and alert. We've asked about her cancer treatments, but no one is giving us any answers or any other recommendations. The case manager has reached out to us to talk about looking for an LTAC. What should we do? I want my mom at home. Yeah, you should absolutely not entertain any discussions around LTAC. Just go online, type in any LTAC in your area, and look up their online reviews. It's probably all you need to know. Look up their online reviews. Look up their online reviews in how they compare with what they're advertising on their website. What they're advertising on their websites is that they're specialized in weaning patients off the ventilator and the tracheostomy. That's what they claim on their websites. And then you look up the online reviews from real people, from real families, and they they can't and they don't. And we've seen it over and over again. I've talked to LTACs, I've talked to families in LTACs, I've talked to patients in LTACs. It's an absolute disaster area. I have done a video maybe about 6 months ago, earlier this year, 10 reasons why LTACs in the US are a scam. And I'm not mincing my words there. Everything that I'm saying on that video, I can back up. Right? They are a scam. Right? So coming back to the cancer treatment, but no one is giving you any answers or any other recommendations. Please keep in mind that now your next step is to speak to an oncologist about lung cancer treatment. Speak to an oncologist, but also speak to a pulmonologist, speak to a cardiac surgeon to see whether they can operate on it. Right? Those are your next steps here. Can your mom go home? I argue with what you've shared here, absolutely yes. Similar to Kim's email, you know, your mom can go home, and the same dynamics apply, right? The dynamics are that, you know, someone is paying for the ICU bed, has been paying for the ICU bed for up to 6 months, right? The ICU wants the ICU or step-down ICU bed empty. Someone is paying for the ICU bed, $5,000–6,000 per bed day. Might be a little bit more cost effective now, given that she's in step-down ICU. But you want her home, and she wants quality of life, right? Or if the lung cancer is untreatable, inoperable, whatever, you want quality of end of life, but you don't want to die in an ICU, I would imagine. Right? So, I hope that answers your question. Right? But this is, you know, just in the last couple of weeks, because, you know, obviously Camille has been told after 1 day in ICU that her mum won't survive the night. Now, we're currently working with 2 clients that are in kind of similar situations, and they've been told their loved ones will die, and they've been told your loved one won't survive the next 2 days, and they're all both still alive after weeks. So you have to question the clinical judgment. I'll come back to that in a minute. I've got a question here from Jadi who says, "Hi Patrick, my girlfriend went to the hospital cause of vomiting. Shortly after, she had a seizure and her heart stopped. They revived her and put her under anesthesia. It's been 48. Will she wake up?" I wouldn't know, Jadi. So, a couple of questions here. How long did her heart stop for? How long did they do CPR for? That's one question, right? And with the seizures, where's that coming from? Has she had seizures before? Is that new? Have they done a CT scan of the brain? An MRI scan of the brain? Have they done an EEG of the brain? Right? Have they started cooling therapy? Is she on inotropes or vasopressors to support her heart? Right? So I have multiple questions here before I can even answer your question. Right? The devil is in the detail, Jadi. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So my question to you is, right, what have they done so far? The other question that I have for you is, Jadi, are you the power of attorney for your girlfriend? Who's making decisions on her behalf while she is in a coma? Right? So let me repeat my questions because I think it's so important. You know, how long has the heart stopped for? Right? How long did they do CPR for? Have they started cooling therapy? Have they done a CT scan of the brain, MRI scan of the brain, EEG of the brain? Is she on inotropes, vasopressors? Right? If she's on cooling therapy, Have they paralyzed her? You know, I don't want to overwhelm you, but the reality is if you don't look at all these things and if you don't understand how they're all intertwined, you will never understand what's exactly happening, right? So if you can give me some answers to my questions, Jadi, then I can answer your question or questions. Coming back to the clients that we're currently working with. So one client is 80 years of age, had a cardiac arrest, went into ICU with supposedly a brain injury, quote unquote brain injury, right? And the family was told right from the get-go that their dad won't survive, that he's only got a few days left, that if he will survive, he will be severely brain damaged and he won't have any quote unquote quality of life. The family disputed that right from the start. They said, no, my dad wants to live and he wants everything to be done. And they were trying to push them to go to an LTAC, do a tracheostomy, go to an LTAC, right, as an alternative. And the family said, no, you got to do a tracheostomy first and then wean him off the ventilator. They were delaying, the ICU was delaying switching off propofol, which was a red flag right from the start. Because if you think that someone is severely brain damaged, you should be able to switch off propofol and all other sedatives pretty quickly to make an assessment of what the brain is doing, right? And what the brain is doing is important for you to understand because, you know, if your family member isn't breaking up when all sedatives are off, okay, maybe end of life is what you need to consider, right? But the interesting part is after the ICU switched the propofol off, the gentleman started to obey commands, right? He was squeezing fingers, wiggling toes, opening eyes. That was after ICU told the family, your dad is not going to make it, right? And if he is making it, there won't be any quote unquote meaningful recovery. Well, what is meaningful? What's meaningful might be different for you than it is for me, right? What's meaningful might be different for you than it is for me. It's not up to intensive care teams to decide what's meaningful. It's up to families to decide what's meaningful. It's up to patients, right? So that's one example where you can't trust the clinical judgment of intensive care teams because they are hidden agendas. And unless you understand what those hidden agendas are, once again, you'll be fighting an uphill battle, right? Next. Another client we are working with had their sister or has their sister in ICU. Similar story. Cardiac arrest, supposedly hypoxic brain injury, no chance of survival. And if they were going to survive, they would be, quote unquote, no quality of life. Well, once again, no perceived quality of life. Once again, what is quality of life? What is it? It's different for you than it is for me. It can't be measured objectively. It can only be discussed subjectively. And it's just that it's a discussion. The decisions need to lie with patients and families, not with intensive care teams, who are very poor at predicting outcomes when it comes to life after intensive care. They're extremely poor, right? We see much more with intensive care at home, what life looks like at home when patients survive intensive care. And I can assure you, all of our clients with intensive care at home want to live. It's not about the perception of quality of life. It is quality of life in their eyes. It is very meaningful for our clients and their families. Extremely meaningful. Now, interestingly enough, this lady that I'm talking about that is in ICU, she is now off the ventilator. She's had a tracheostomy and she's now coming close to having the tracheostomy removed. She's already speaking with the speaking valve. She's already eating and drinking. She's very close of getting the tracheostomy removed. That is amazing. And keep in mind, once again, that is after ICU told the family she's not going to survive. And if she's going to survive, she won't have any quote unquote quality of life. Unbelievable. Once again, can you trust judgments of intensive? Can you trust the clinical judgment of intensive care teams? No, you can't, because it's driven by an agenda. The same with this lady. The ICU team was trying to force the family to go to hospice. Right? Hospice means end of life care. Right? It is ridiculous. I've done a video a few weeks ago with the title, "Where's the hurry in killing someone in ICU?" Or "Why do ICU teams hurry to kill patients in ICU?" Something along those lines. Why is that? We as health professionals have all sworn to help people. Now, I have yet to find out when it's a good idea to let someone die, unless, families, patients want that. But most don't. So where have we gone wrong as health professionals? Where have we gone wrong? Okay, so next. Let's move on to the next question, which is from AJ. And before we go on to AJ's questions, if you have any questions, type them into the chat pad or connect live with me here on the StreamYard link. I put the StreamYard link into the chat pad here. You are welcome to talk to me directly here on camera or off camera. The quickest way I can help you is talking to me directly here, either in the chat pad or on StreamYard. Let's go back to AJ's question, who says, "Hi, Patrick. I'm the guardian power of attorney for my sister. She has cerebral palsy, scoliosis, epilepsy, osteoporosis, and a PEG tube. She's been hospitalized with aspiration pneumonia for 5 weeks now. She had a recent PEG tube and now just got the tracheostomy 2 days ago. The focus has been on securing her respiratory, I think you probably mean her airway. But now her GI issues, her gastrointestinal issues, began with the hospitalization and all the medications on and off for 5 weeks now. She has gotten very little nutrition, original weight of 70 kilos. Now she's looking very, very skinny. She's losing weight. She's still going slow on the feeds and getting high residuals. The concern is that she's not absorbing or processing her feeds. Her heart rate and blood pressure were high all day today and not resolved with other things. I asked about TPN. And for anyone that doesn't know what TPN is total parenteral nutrition, also known as IV or intravenous nutrition. And they can't do a PICC line because of her anatomy, so it would have to be a portacath. But the doctor is saying no, it's too high risk for infection. I'm freaking out now, thinking they're just going to let her die. What else can I do? Do I keep pushing or ask to transfer to another hospital? I also asked to transfer her home before, and they said no. They have now suggested an LTAC, but we want her to come home, but want her nutrition sorted first. Yeah, of course. You will need nutrition sorted first. It's an absolute no for her going to an LTAC. Don't let them push you around, right? They need to urgently sort out her nutrition, because if she's not getting any nutrition, she is at risk of dying. Very simple. She is at risk of dying, right? And we have seen patients die in ICU because of they're getting no nutrition. So you better be on the one step ahead, right? Another thing that is important here is, she's having a PEG, and you would have heard me say in many other videos, don't give consent to a PEG when you have a loved one in intensive care. Now, in this situation, I will make an exception, especially since your sister has cerebral palsy. There is a very high chance she will need a PEG in the long run. There's a very high chance for that. there's a very high chance she will need a PEG tube in the long run. And therefore, I argue the PEG is the right decision here in this situation, right? But it's an exception, it's not the rule. Okay, so and with cerebral palsy, it is also unlikely that your sister can be easily weaned off the trach and the ventilator. Not impossible, but more difficult to be weaned off the ventilator and the tracheostomy, just simply because also she's got scoliosis, right? She's got epilepsy, which puts her at high risk of aspiration. So she has many, many risk factors that will most likely not prevent, but make it very difficult for her to wean off the ventilator, especially since she was admitted with an aspiration pneumonia. Now, some of her nutritional issues might be at least temporarily solved with the PEG tube, right? That might help her to solve some of the nutritional issues, right? But if the PEG isn't going to work either, if she can't absorb with a PEG or a PEG, she will need TPN. And no, a port catheter is not a high infection risk. It just needs to be managed. Not getting nutrition at all, I argue, is an attempt to kill your sister. So the argument about it's too high infection and then then not giving nutrition is a false argument. That's like saying we should stop eating and drinking because food might be poisoned, right? It's the same principle. We're not going to stop eating just because there's a small risk that food might be poisoned or contaminated. Contaminated is probably the better word, right? Very simple. People need food. People need to eat and drink. And if they can't eat orally, they need PEG feeds or TPN or nasogastric tube feeds. But it sounds to me like PEG feeds are out of the equation at the moment. PEG feeds, they have yet to try. And if that's all going to fail, there's always the TPN. And it is not a high infection risk. It just needs to be managed. The infection risk is high while she's in a hospital. That's the issue, right? The minute someone can go home, the infection risk is much reduced, right? So think about that, because in hospital, you're getting infections because you're surrounded by bugs. You're surrounded by other sick people. At home, you are in a clean home environment, not surrounded by ICU bugs, by very sick people, right? And if she's losing weight and she's not being fed, she's at risk of losing more weight and she's at risk of dying. It's an attempt to kill her. And then the longer you don't feed someone and you then restart the feeds, there's a risk of refeeding syndrome. You don't want the risk of refeeding syndrome. You just don't. It takes much longer to get a patient back up to normal nutritional levels. Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Now, what are your next steps here, Camille? AJ, sorry, it's AJ. Your next steps are to take your sister home, I believe. She's much better off at home once you have the nutrition sorted, right? And we can help you in the United States with intensive care at home. We can help you there privately. So please reach out to us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecareathome.com or to info@intensivecareathome.com. Now, next question. Hang on, just give me 1 second. And if you have any questions in the meantime, just type your questions into the chat pad, or connect with me here live on StreamYard, right? And then you can talk to me directly here. Okay, so here is a comment from Jamie. Jamie says, "Hi Patrick, thank you so much for your great YouTube channel and for all your great videos. Now, my 74-year-old dad has been in the ICU for a little over 2 weeks. Originally presenting with subdural hematoma, he had a successful microdrilling procedure, which is also known as a burr hole, but suffered stubborn seizures, but they threw every medication they could at it. It's been about 5 days now that he's been off phenobarbital, fentanyl, and a few others, as well as lowering the seizure medications without any new seizures presenting. But we have not been successful in getting him to wake up yet, and he's still on the ventilator, although he overbreathes on it on minimal settings because his heart, kidney, lungs, and liver are very healthy. They tried a ketogenic diet, but he couldn't produce ketones. I did mention to them the possibility of the ambient counteract to try and take him out of the coma like they do in South Africa. Any other suggestions are super appreciated. I should also mention it was a chronic subdural hematoma from a fall a month ago. He has had clear CT scans ever since and a successful drain in the first 48 hours post-op microdrilling. Once again, the microdrilling is also known as a burr hole procedure. So, gotta moisten my throat. If your dad has been on phenobarbital and fentanyl and a few other sedatives that, as you're referring to, you need to give it some time for him to wake up, right? Phenobarbital and fentanyl are very, very potent medications, and especially the combination of strong sedatives, high doses of strong sedatives, and high doses of strong opiates such as fentanyl, and a subdural hematoma can take a long time for patients to wake up. And you might need to be patient. And in the meantime, you need to make sure your dad gets physical therapy, gets stimulated, right? Gets ideally moved around, right? If he's been in ICU for over 2 weeks, he might have a tracheostomy by now. You haven't shared anything in there, what he's up to, right? Yeah. In terms of the nutrition, in terms of the ketones, you do need to speak to a dietitian here. That is not so much my area of expertise. You will need to speak a dietitian here about what is the next best course of action in regards to his nutrition, right? Also, if he's got what you are describing as stubborn seizures, right? If you're describing stubborn seizures, I also want to find out what anti-seizure medication is he getting? What is he on? Right? And how is that potentially contributing to him not waking up? Right? Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what you are dealing with here once again. Right? So what would I suggest here? Be patient. Be patient. Make sure it's all sedatives. Get an idea what anti-seizure medications he's on. You know, we can help you with a medical record review. We can help you with talking to the doctors and nurses directly. You know, we can go through a series of questions that I can ask them, and then you will see what counter questions I have, right? Because it's one thing for you to ask questions. It's another thing not to then have another question ready depending on what they're saying. That's where all my intensive care nursing experience is coming in. Right? Very, very simple. Very, very simple. Right? You can't fly blind when you have a loved one in intensive care. You just can't. You know, most families in intensive care do fly blind. Right? They do fly blind. Okay, so let's go on to the next question, which comes from oh, it doesn't have a name in any case. And if you have any questions, before I get on to the next question, if you have any questions, please type them into the chat pad or talk to me directly here on the video. Click on the StreamYard link. Right? Okay. Here's a question from a reader who says, my mom has a ruptured aneurysm clipped surgery. It's been a week. She's in ICU with ventilator support, and she had a tracheostomy as well. She's not opening her eyes. But nurses are saying she's slightly opening her mouth and move sometimes. She's only 58 years of age. Does it take a lot of time for her to wake up and talk? Great question. So, if your mom had a ruptured aneurysm clipped, what that means is she had emergency surgery. An aneurysm, depending on which blood vessel it was in, right, was it at a major artery, you know, you could bleed to death within minutes. So someone must have made the right calls here, and someone must have made the right calls here, and you know, done surgery to save your mum's life. Now, a ruptured aneurysm can be a long surgical procedure. And when patients come out, they've often lost a lot of blood, right? They might have been close to a cardiac arrest because of the massive blood loss. They would have received multiple blood transfusions, right? During surgery, potentially even after surgery, right? They would have received most likely multiple inotropes and vasopressors to keep your mum alive. That means her body has taken a massive hit, right? Many patients after an aneurysm rupture and surgery, ruptured aneurysm, end up in kidney failure. Why is that? When there's a ruptured aneurysm in an artery, most likely in a major artery, because that's where most aneurysms develop, the kidneys will get no blood perfusion during that period, right? So, with that said, the kidneys take a hit. So, you got to ask a series of questions here, right? So, why is she not waking up? Well, she's simply critically ill. A week after a ruptured aneurysm is not a long time, right? Patient has to be stable after a ruptured aneurysm to be woken up. Your mum is probably not stable yet. So the questions that you need to ask here, before you ask when she will wake up, are, what level of support is she needing at the moment? She's got a tracheostomy. Why does she need a tracheostomy? It's only been a week. Tracheostomy should be done 10 to 14 days when a patient in intensive care has shown, beyond the shadow of a doubt, that they can't come off the ventilator and the breathing tube. That's when a tracheostomy should be done. The other question in a situation like that is, what have they done to avoid the tracheostomy and wean your mum off the ventilator and the breathing tube beyond the shadow of a doubt? Now, that ship has sailed because she's already got a tracheostomy. But that is a question that you should have asked. That is a question you should have asked. once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for, they don't know what questions to ask, they don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is exactly what you are dealing with once again, right? So, if she's still on inotropes, if she's still on vasopressors, if she's still sedated, right, of course she's not waking up. If she's not sedated, why is she not waking up, right? If she's not sedated and she's been off sedation for 3-4 days, she's not waking up, is there potentially some form of brain damage? Well, if there is some form of brain damage, they better find out, and they better find out now. Therefore, they would need to do a CT scan of the brain, an MRI scan of the brain, or an EEG, or all of it combined. Here is another question. If she had an aneurysm rupture, depending on how much blood loss there was before she went to surgery, she might have been very close to a cardiac arrest. Maybe she had a cardiac arrest. Are you sure that she didn't have a cardiac arrest? Right? If she had a cardiac arrest, there's a higher chance that she might have sustained hypoxic brain injury because of no oxygen to the brain for more than 3 minutes. If you ask all those questions, do you have access to the medical records? Are you the power of attorney for your mom? Right? Is she potentially still bleeding? Right? How did they fix the aneurysm? Did they take out a piece of the blood vessel and remove the aneurysm, or did they potentially stent it with a stent? Numerous questions here, right? I hope that helps. I hope that helps. Okay, so now let's move on to the next question. If you have any questions in the meantime, type them into the chat pad or connect live with me here on the StreamYard link. I'll be going roughly for another 10 minutes, right? I'll be going roughly for another 10 minutes. And then I'm going to wrap this up. So now's your chance to ask questions. And if not, I will move on to the next question that came in via email this week. And here is a question from Sandra. Sandra says, "Hi Patrick, my mum is also in ICU due to a neglected wound causing septic shock. The kidneys are failing and the blood pressure went down, as well as she was on dialysis and treated the wound, but they keep on sedating her. She has diabetes type 1, as well as she's on ventilation. I don't know if she will survive." Well, Sandra, I'm very sorry to hear about your mum's situation. Now, I'm not surprised that a neglected wound caused septic shock, and that is what got your mum into ICU. That's number one. I'm not surprised that the kidneys have failed after septic shock. Unfortunately, I've seen it. I looked after thousands of critically ill patients and their families in ICU over the years. I've seen this many, many times. Septic shock, kidneys are failing, blood pressure went down. She would be on multiple levels of inotropes and vasopressors, such as norepinephrine, noradrenaline, epinephrine, adrenaline, vasopressin, levophed, dopamine, potentially dobutamine, and the list goes on. So she was on dialysis and they were treating the wound, but they keep on sedating her as she has diabetes type 1. I don't think that they keep sedating her because of diabetes. I don't think that's the case. They keep sedating her because she's potentially not ready to wake up. potentially the antibiotics are not working for the septic shock, right? So will she survive? I don't know. I don't know. Approximately 90% of intensive care patients survive. That's 9 out of 10. There is a higher mortality rate for septic shock in particular. There is, right? So the odds are probably slightly less, but I've seen many patients with septic shock survive. Now, my first question to you is, do you have access to the medical records? Can you get a second opinion? Get access to the medical records, reach out to us, and then we can look at the medical records and we can make sure they're doing all the right things. Right? You need a second opinion. Right? And why do they keep sedating her? Maybe she's fighting against the ventilator. Maybe she's on too many high doses of inotropes or vasopressors. Maybe she's not tolerating the ventilation. Maybe she's not tolerating the dialysis. The devil is in the detail when you have a loved one critically ill in intensive care. Absolutely in the detail. Right? So, you must never give up hope. But what you need to do in situations like that as well is you need to make sure that your loved one gets best care and treatment. And you will only find out if your loved one gets best care and treatment if you get a second opinion. You know that not all intensive care teams are truthful, and you know that not all intensive care teams have your best interest at heart. And you can only find out if they have your loved one's best treatment interest at heart is to get access to the medical records, or if you let me talk to doctors and nurses directly and ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. Right? Very simple. Simple, but not easy, because then you have to ask the right questions. Then you have to ask the right questions. All right. But, like I said earlier, you have to question everything. If you're not questioning everything, you are doomed. Right? You are doomed. I have seen many ICU teams over the years telling families, oh, your loved one's not going to survive. And yet we all knew that 90% roughly of intensive care patients survive, the overwhelming majority. So why would your loved one not survive? What's the agenda here? The agenda for ICU teams is to maximize revenue, manage beds. That's the agenda. That is the agenda. Right? And stay in control who they believe should live and who should die. Scary. Scary stuff. Right? But you are awoken now. You have awoken now. You're in the right channel. You're in the right program to open your eyes. Right? You're in the right program to open your eyes. So, now last chance for you to ask me a question. If not, I will wrap this up in the next 5 minutes. Ask me any questions you like. We still have a couple of minutes. If not, I just want to wrap this up today by saying, once again, question everything. And don't let the negativity of intensive care teams bog down. Like I said, we have saved many lives with our consulting and advocacy. We have saved many lives with intensivecarehotline.com, and we have saved many lives with intensivecareathome.com. And I encourage you to read up both testimonial sections on our respective website, intensivecarehotline.com and intensivecareathome.com. Our clients love what we do, right? Because we have changed many lives. We have transformed many lives, right? And we can do the same for you. We are actually going to do the same for you, if you reach out. If your situation is dire, or if your loved one's situation is dire. There's always help at hand. There's always help at hand, but you have to be willing to turn situations around, no matter what you think the odds are. Doesn't matter, the odds don't matter. If you're faced with an impossible situation, right, you don't need the muscles of a Hercules. You don't need the mind of an Einstein. You simply need to know what to do, right? You simply need to know what to do. And we know what to do in most cases, right? Hi, Tom. Nice to see you again. I hope all is well on your end and your family's end. Thank you. All right, I'm going to wrap this up in a minute. So if you need one-on-one consulting and advocacy for your family member in intensive care, go to intensivecarehotline.com. You can book a free 15-minute consulting session with me, and I also have paid consulting and advocacy options. We also have a membership for families of critically ill patients in intensive care, where you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access for 21 ebooks, 21 videos that I've personally written and recorded that will help you to make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment always. With intensive care at home, we send critical care nurses into your home, and we provide a genuine alternative to a long-term stay in intensive care. And we do that currently all around Australia, in all major capital cities, as well as in all regional and all rural areas. We are NDIS approved in Australia, DVA approved in Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, as well as NIISQ in Queensland. We have received funding from public hospitals, private health funds, departments of health, and so have our clients. And we have always successfully advocated for our clients for the funding for intensive care at home. Otherwise, we would not be in business. If you're in the US or in the UK and you're watching this and you want intensive care at home, please reach out to us as well, because we can help you there privately. The website is intensivecarehome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecarehome.com. With Intensive Care Hotline, we also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. Also, with Intensive Care at Home, we are also providing NDIS support coordination level 2 and level 3. We're also providing NDIS nursing assessments. We're also providing TAC and WorkSafe case management in Victoria. So I'm going to wrap this up here. Click the like button, subscribe to my YouTube channel, share the video with your friends and families, leave your comments so I know what questions you have, what content you want me to produce. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you again next week. Take care.